Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Understanding Erectile Dysfunction. It's my pleasure to introduce our speaker, Dr. Tony Chen. Dr. Chen is a fellowship-trained urologist who specializes in male reproductive medicine. He is a clinical assistant professor in the Department of Urology at Stanford University School of Medicine. Dr. Chen diagnoses and treats male infertility, erectile dysfunction, and other disorders of the male genitourinary tract. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Chen will answer as many of those as possible. Over to you, Dr. Chen.
All right, thanks, Elisa. So let me get my slides shared. All right, nice to have everyone come zoom in virtually for the Stanford Health Library Community Lecture Series. I'm again Dr. Tony Chen, one of the men's health urologists here at Stanford, and I'm here to just give a very sort of patient-centered look at erectile dysfunction. And hopefully many of you will find this elucidating and empowering also. So without further ado, okay. I have no financial disclosures or ties, and it's just for fun. I like to tell people now that I don't use any AI in my slide generation or making. So this is all me, for better or for worse. So for the objective for today's talk, we're going to just look at the relationship between chronic disease states and erectile dysfunction, sort of cause and effect, and what that means for you. And also just look at the very diverse treatment landscape for erectile dysfunction. There's a lot of tried and true things, and there's a lot of sort of less understood new things out there. But I'm sure you're getting ads for all of them. And this is kind of the common, I guess, old school Viagra picture they kind of throw out there. Just like these men, just very. It's a disorder that comes with a lot of isolation. I think there's not a lot of people to talk about this with. It brings in, it's not just like a physical thing, it's an emotional, it can be spiritual, cultural. There's a lot of things that make this a hard disorder to have, or dysfunction to have. And in fact, 1 in 5 of US men over the age of 20 have some degree of ED. And when you look at men over the age of 40, about half of them have said they had some ED. What that specifically means, we'll go to the next slide, how I got those numbers. But basically, erectile dysfunction, some patients come to me and ask, do I have it? How do I know I have it? And essentially, it's a very subjective metric. It's the inability to get and maintain an erection firm enough for sex. And it also has to cause some degree of bother. So whether someone has a decent erection that just is not where they want to be, and it causes them some insecurity, it causes their partner some displeasure, that is erectile dysfunction. It could be someone that just had a radical prostate surgery and has 0 erections, and that's definitely also erectile dysfunction. But sort of the patient-centered part of this is that it does cause bother. And we look at the prevalence of ED. This is one of the most sort of very well-cited studies called the Massachusetts Male Aging Study, where they looked at more than 1,000 men from 1987 to 1989, so a while ago. It hasn't really updated. But again, this 52% that you'll hear often, not from myself, but also other urologists, is that 48% said, I never have any issues with erections, and 52% of people have said that they have either some or usual or always some erectile dysfunction. And that's why we got that number. And we're going to take a step back and just look at what is erectile dysfunction, how does it even happen in the body, what does it mean? And this picture I got from my mentor, Dr. Thomas Walsh at University of Washington, where I trained for residency. But he liked to always put this picture up as hydraulics. Erections are all about hydraulics, plain and simple. It's not a very complex principle in that sense, where fluid goes in and it doesn't come out, and so you generate pressure and force through it. And when you look at the human body, where does that where does that hydraulic system lie? Well, here is the anatomy of an erection. Here's your penis in cross section, and you'll see these 2 paired sort of oval shaped things at the top and a singular lumen in the bottom. Well, for erections, we're talking about the top 2 structures. Those are called the corpora cavernosa, and they're paired structures that are basically interspersed with a complex network of endothelial cell lined lacunae, or basically arterial inflow. It's like a spongy tissue that just fills with blood, and it is surrounded by a very dense, in this pale colored picture graphic, but it's a very dense structure called the tunica albuginea. It's like a fibrous elastic covering. And so during an erection, the corpora cavernosa fill with blood and compress the veins that are on the edges of the peripheries of the corpora cavernosa against the tunica albuginea, And so what you get is more blood going in, blood can't come out, and it gets basically harder and harder to get an erection. There's a complex process between, when you're normally not having erection, there is blood flowing through the penis, but it's basically blood in and blood out is balanced. And then again, in the erect state, you essentially have blood going in and not coming out. And in terms of the physiology of erection, there's typically, the stepwise process. If there's some type of arousal, either mental, physical arousal, or reflex, aka some sort of sensation, it could be by vibratory touch. It could be even like scent or smell, something with arousal. Nerve signals go towards the corpora cavernosa and release nitric oxide, which basically will let those blood vessels dilate and allow more blood in. The smooth muscles relax, dilate, more and more blood goes in, the veins get compressed, and blood can't come out. So for the rest of the talk, for context, excellent erections require adequate blood flowing in, passive venous compression, so blood not going out, an intact nervous system, so some type of sensorium that must sort of allow for arousal and these signals to get to where they need to get to. Number 4, we don't talk about this very much for this talk, but adequate testosterone levels. And then 5, regularity of use, meaning the penis is thought of as a use it or lose it organ, and so there's a long period of disuse. So, some men will say, I haven't had an erection for 1 or 2 years after some type of insult or injury or surgery. Then we have to sort of, claw that back a little bit if we can. And when you look at the causes of ED, we always the myth was always that it was all in your head. But actually, if you look in reality, most of erectile dysfunction has a physical root, some type of physical ailment leading to this sort of dysfunction, what we talked about, the blood flowing in and out, the balance there. There is a psychosocial component, or 10%, maybe some performance anxiety related to it. But by and large, I never assume that ED is psychogenic or all in your head. I always kind of look for what might be a root cause that we can either take into account and look at treatment options, or to sort of give you a better, make sure that we're affecting other lifestyles choices that you're having. When you break that down, what does this look like? The top 3 insults that cause ED are, number 1, vascular, and I'll spend a couple slides on the vascular or blood vessel health part of this, because that's sort of the biggest, take-home point from a cause of ED standpoint. 30% can be related to diabetes, 50% related to medications, and then there's various things like pelvic surgery, especially of the prostate, neurological causes like multiple sclerosis or Parkinson's, or endocrine problems like testosterone. And so you'll see that testosterone is not a huge, big part of this. But this chart sort of oversimplifies things, because there's obviously a huge overlap between diabetes and vascular disease, and people that take medication for all those for those diseases. So there's a very big balance that you'll see there. The first thing I want everyone to understand is that we are finding out more and more just how significant erectile dysfunction is as a risk factor or as a clue into your overall cardiovascular health. In fact, numerous studies have come out to basically say that erectile dysfunction, having it, is an independent risk factor for cardiovascular disease. What does that mean? Like having a heart attack, essentially, or other issues. In someone with erectile dysfunction compared to someone without erectile dysfunction, when you match sort of their age and their demographics, the one with erectile dysfunction has a 1.25 to 2.5 times higher risk for heart attack than those that do not have ED. And this is similar to smoking. So aka like a smoker has a higher risk of heart attack than a non-smoker. Same thing with someone with erectile dysfunction. And having sort of new or noticeable onset of erectile dysfunction may precede a heart attack by 3 to 4 years. So definitely we don't want to just think of the penis in isolation. The penis is in continuity with the rest of the vascular system of the body, and it's a proverbial canary in the coal mine. And it doesn't just stop at cardiovascular disease. Having ED also increases your risk of stroke, peripheral artery disease, and all-cause mortality. So frightening. Am I using this to scare you a bit? Maybe, just as a wake-up call for some men, actually. And the more severe the ED, the higher the risk of these things happening. And actually, the younger age of erectile dysfunction, the higher the risk as well. So someone with erectile dysfunction in their 40s and, like, let's say 40 to 50 range, their sort of danger of having one of these, severe cardiovascular diseases is much, much higher than someone that just started having some erectile issues in their like late 60s or 70s. And why is that? Let's take a look at that. So the risk factors for erectile dysfunction and cardiovascular disease and stroke and all these things are basically the same as everything else, right? They affect blood vessels. And so that's high blood pressure, diabetes, high cholesterol, depression, and chronic stress, smoking, obesity, a sedentary lifestyle. And if you dig into a little bit deeper, why is that? Well, all these erectile dysfunction, MI, stroke, they all occur when the blood vessel feeding fresh oxygenated blood is being blocked off. And the arteries to the penis are much smaller than the other arteries. So if you're going to have issues like plaque buildup and obstruction, those happen and cause problems much earlier when the blood vessel is smaller. So on the chart you see here on the left side, the arteries going to the penis, 1 to 2 millimeters in size. And the ones going to the heart, 3 to 4 millimeters in size. So you can see if you're going to have, think of plumbing, you have plaque buildup or something clogging the pipes, that clog is going to be much more apparent in the erectile dysfunction column than in the heart attack column. But whatever's underlying those things, either like cholesterol, diabetes, all these things, is the same. And speaking of ED and diabetes, it's very similar. In terms of the mechanism, there's microvascular insults where the nerves can be injured by chronic hyperglycemia. There's macrovascular insults where there's obviously sort of a hardening of the arteries with chronic high glucose levels, but the underlying risk factors are very, very similar. ED is definitely more common in men with diabetes, so 3.5x higher than in men without diabetes. And the higher your A1C, the higher risk of ED, and the lower your ability to respond to medications and treatments that we'll talk about later. People do ask me, oh, doc, are these meds that I'm on causing ED? There's definitely a long list of medications, and here's like sort of the common list of them. Blood pressure meds definitely at the top, like thiazide, beta blockers, spironolactone, digoxin for atrial fibrillation. If you're on hormone-altering medications like finasteride or dutasteride, those can affect things, especially if they're taken orally. They're topical formulations for men with hair loss or risk of hair loss, and that has a lower chance of causing systemic side effects. That's something to be aware of. Prostate cancer medications, definitely prostate cancer treatment of any kind can cause ED. Antidepressants, opiates to treat pain. What I typically tell people that do have medications on this list is that I can't just, have you go off of many of these meds because you're needing them for some health-related reason. So what's better to do is to talk to your PCP or prescribing doctor. There's like a better alternative. But definitely, if you took off your blood pressure meds and you had uncontrolled blood pressure, that's probably worse for your erections in the long grand scheme of things than just being on this medication. So back to the original slide, people are frustrated. What can we do? Well, at least in urology, we're very pleased with how many tools we have to fix this issue. And myself and my mentor, Dr. Eisenberg at Stanford, we always say, if you have a penis, we can make it hard. The question is sort of how far down the path you want to go. And this is an overview of the erectile dysfunction treatments from the American Urological Association guidelines. And the important thing to note here is that all of these treatments listed on this page, which we'll go through one by one, are sort of valid as first line. That means the doctor shouldn't say, well, you can't get this, you have to fail all these things first. You can very much sort of jump into whatever might fit whatever your goals are. But be sure that before you make that jump, that you actually know all the risks and benefits and ups and downs before you make that choice. I am still a fan of graded approaches, just so it's less invasive and more invasive, and you'll see what that means as we go. But these are the things we'll talk about today. So lifestyle modification. With what I've told you now, if you have any cardiovascular risk factors and you have ED, definitely seek a PCP. If you don't have a PCP, get one. It's also alarming that a third to 40% of men don't have a PCP. So I usually, from my clinic, say, well, this is your time to get one because you don't want your ED to get worse and you don't want this, canary in the coal mine factor to blossom into like an MI or a stroke if you don't get that managed. Smoking cessation, alcohol moderation is all important. Physical activity. So the American Heart Association recommends at least 150 minutes per week of moderate intensity aerobic activity. So if you're not near that, it's always easier said than done. But the more activity you do, the better it is for your penis. So hopefully you'll do it for your penis. For those with diabetes, I've seen men turn things around when I tell them, hey, you get your A1C down from like 10 to 7, you'll be much better. And they've sought endocrinology, they've gotten the glucose monitors, they've got on insulin, and they're scared to get on insulin before. And so turning things around, using your sex life or your potency as a motivator definitely can be helpful. And if there are some psychogenic or partner couple factors that you think could benefit from sex therapy or mental health, then there should not be any barriers to seeking it. So moving on, let's talk about the tried and true, the oral therapy. You've all heard of at least Viagra. So most of you have heard of Cialis. There's also other ones like Levitra and Stendra. They all essentially work the same way. The difference is just how long they last in your system, how quick they take to start acting. But essentially, what they do is they send more nitric oxide, they allow more nitric oxide to be released and to stay around when your erections are occurring, so that again those arteries are open, the smooth muscles are relaxed, so blood can keep on going in and staying in to help you achieve an erection and maintain an erection. And the advantages are that it's on-demand use typically. You can't do daily Cialis on a daily basis, but most of these like Viagra, Levitra, Stendra are intended as on-demand use. They're easy to prescribe. They're very common now. I think there's like a very, very excellent safety and efficacy data around them. The limitations, there's some limitations on spontaneity. You have to kind of time them. You have to put it on the calendar. Some people don't like that, but this is a very sort of low barrier to entry. And there are systemic side effects that make people not very happy. They can cause, headache, flushing of the face, indigestion, backache, leg cramps sometimes. Some people get some blue tinge to their vision. But by and large, this is where a lot of people start their ED treatment journey, and where a decent chunk of people just stay there. Actually, they don't need more. And if you're on this talk and you're on these and they're not working perfectly, and you haven't talked to a urologist yet about them, there's definitely some steps to optimize how to use these things. And so we definitely always start with lifestyle changes, and I like to tell my patients that in a trial or a study where when they looked at men who used Viagra alone versus men that used Viagra and they started like an exercise regimen, those that had exercise plus Viagra had much better response to the Viagra. That just, I think, makes intuitive sense. I think exercise is good for, again, like we talked about, all the cardiovascular risk factors. It's good for hormonal factors, increase your testosterone, all these things. That leads to the second point. Ensure normal testosterone levels. So I think it's always fine to check a testosterone level when a man presents with new onset ED. Definitely the younger you are, I think the more it's on my radar. I tell people that if your testosterone is normal, making it much higher is probably not going to fix the ED, because the underlying cause of it, like you saw before, is more of a blood flow issue. But if your testosterone, say, is so low that your libido and arousal levels are so depressed, then I think there is some room for testosterone treatment alongside erectile dysfunction therapy. I tell my patients that these pills don't give you automatic erections. You need to be aroused and in the mood for them. And that's one missing piece. Sometimes people take it and they just wait and nothing's happening. They think it didn't work. Finally, not finally, but you should look at correct timing and consequence of meals. What that means is some medications are longer lasting, some medications are shorter lasting. So things like Avanafil, very quick acting, so you can take 15 to 30 minutes before you want to have sex. Viagra is the classic, like 1 hour before sex. Cialis, it's slower to absorb, but also slower to be gone from your system. So we tell people 2 hours before sex for Cialis, and it can last up to 24 hours for some people. And the consequence of meals, very, very important, not very often talked about, but Viagra is probably the most sensitive one, should be taken on an empty stomach. And some people, like, when I tell them that, like, oh, no one's ever told me that, and I've been eating it with like steak dinners and things on dates. So definitely that one is the most sensitive to meals. Moving on, if you've never tried this medication and you're trying it for the first time, try it without a partner present to minimize the stress and performance anxiety of it. Just be by yourself, take it with the appropriate timing, have some self-stimulation or self-arousal, and see how that goes before you try it with a partner. Try each medication at least 8 times, so on 8 separate occasions, just because there's so much variability in just how we have sex as human beings. That there's different. Maybe you didn't sleep well. Maybe you had a stressful day at work. Maybe something happened in traffic. Who knows? And that can affect how you respond and just how your general sort of mood is. That's why I just don't just take it once and it doesn't work and just tell your doctor, oh, that sucked. Try a couple times. If one isn't working because of side effects, like if you had headaches with Viagra, well, try Levitra or try Stendra. Shop around a bit for side effects. So even though they work similarly, they do have different odds of different side effects. We do this more and more now, but if you're on a daily Cialis for erectile dysfunction, you can boost it essentially by taking a daily Cialis every day and taking on-demand like Levitra or Viagra right before sex to just give an extra boost. Sometimes when we send this to the pharmacy, the pharmacist will say you can't do that, and then they send them a note saying yes they can, but that's something that you can always talk about with your provider. We just tell people to just watch out for, these medications do dilate blood vessels in the penis, but they can also cause a slight lowering of blood pressure. And so if you add these things, that can make the blood pressure extra low. So just be aware of that. I think the most game-changing point to this whole slide actually is that your erection pill should not cost you more than about $30 for a 3-month supply. And I'm trying to get the word out more and more. And again, I have no financial ties to this specific online pharmacy, but the sort of Mark Cuban cost plus drug company has really, offered these drugs at sort of what they should have costed this whole time. So this is the screenshot I took, I think, this past week, where a 90-day supply of 5 milligram daily Cialis costs $8, including shipping. Oh, little, yeah, $7.93, including shipping. And so if a barrier to you taking daily medications or even like using Viagra as often as you want is cost, then have your prescribing doctor look into this cost plus drugs website. Other things that can help patients would be like GoodRx. It's a common one here as well. But I think in general, these prices are more reliable than shopping around different pharmacies than GoodRx. And again, they're generic versions of these drugs. And I tell people that generic is the same efficacy as the brand name. It has to be legally. And so that's that our segment on oral therapies. In terms of the other options, this is a new kid on the block that people are asking a lot about. This is a Roxone over-the-counter topical gel, first FDA approved over-the-counter medication for erectile dysfunction. They say it's fast working, no systemic side effects. I have not been very impressed with it so far. My patients have not been either. You can buy this, anyone over the counter on Walgreens, Amazon. I tell people that like the limitation is that it doesn't have any actual medication in it. If you Google it, sometimes there's websites that mislabel it as containing some like nitroglycerin-esque components that can increase blood vessel dilation. But the one being sold and the ones that the data led to the FDA approval didn't actually have any medication in it. In fact, how it works and how they say it works on their website is that this, the number one ingredient is alcohol, and then there's glycerin and aqua and propylene glycol, so very like inert sort of lubricant gel-like things. Is that when you apply the gel on the head of the penis, that when it evaporates, that sensation stimulates some nerve endings that then sort of cause a semi-arousal state leading to blood flow, vasodilation, and erection. The study said that it was about as good as Cialis, actually 5 milligrams, but I don't believe it, at least in the real world, because there's no pharmacologically active ingredient in this. It's just evaporation. But I will say that, I never poo-poo another option, so I'm always glad there's something else that's out there, and it's cheap enough to try. That patients that ask about it, I'm like, try it for yourself and let me know. There's always a vacuum for the next step in our sort of toolbox of things to treat erectile dysfunction with is a vacuum erection device. And what that is a cylinder you put on the penis, a flaccid penis, and as it sucks the air out, it pulls blood into the penis and causes an engorgement, causes an erection by sort of physical force, not by your body pushing blood in. Again, if you can use it on demand, no systemic side effects. So if you can't take oral pills or you can't respond to medications, this is something that physically can help. And then when the erection is sort of in place with the vacuum in place, you put a constriction ring at the base of the penis, and colloquially some people call it a cock ring, but you put the ring at the base of the penis and it keeps the blood in the penis. And you can, I recommend don't using it, not to keep it there for more than 30 minutes, because it can cause numbness and something like that. But it can be a good use for intimacy and you can have an erection firm enough for penetration oftentimes. You should not really, you should be careful using this if you're taking blood thinners that can cause bruising. But some people that are on blood thinners can use this successfully. The next step up that people don't hear much about is the intraurethral alprostadil or suppository. This essentially, it used to be a pill that you then sort of insert into the urethra, the deployment device. That is off the market. And so now compounding pharmacies will just compound a gel. This gel that you put in on demand about 15 to 30 minutes before sex. You massage it into the channel to get it absorbed. The advantage is there are no needles or injections. It doesn't have systemic side effects. So some guys that have like heart concerns or they're on their cardiologist is like worried about them being on Viagra or PDE5 inhibitors. This is a good option to try. The limitations is that the effectiveness isn't as good as something more invasive, slightly invasive, like injections. That can cause some urethral burning or soreness and some of the side effects. It can be expensive. Or the Muse version of it, that was sort of the one you can buy at the pharmacy, was more expensive. Now the compounded cost is about $150 for 10 uses or so. And so this is less talked about because what's often talked about, if you don't, if the pills don't work for you, many clinics will jump to the injection, which I'm listing here. This does work very well. Basically, they inject a cocktail of medications, either bi-mix of 2 ingredients or tri-mix with 3 ingredients, composing of like phentolamine, papaverin, or eprostil. These are 3 things that, again, do try to target those same receptors and same pathways, where they just increase the presence of nitric oxide, so these smooth muscles can dilate and allow blood flow in. And it's very effective. It emulates a natural erection because it just really juices up the vasculature and lets the blood get pumped in. Some limitations, some men are needle phobic, and I try to reassure them that this needle is very, very, very tiny. It's like often a 20 to 30 gauge needle, oftentimes as thin as your hair. Some people don't like that it's not as spontaneous, or if it is, if you're in the mood, you have to bring out like a syringe and some medications that kind of medicalize the experience of it. It can cause pain in some patients with ED that may not have needed a huge high dose of this. It can cause priapism, and that's like the medical emergency of an erection that lasts longer than 4 hours, causing pain, and you have to get it taken down medically. And the effectiveness is variable. In some patients, it can, if you keep on injecting the same site over and over again, it can cause some scar tissue buildup and lead to what's called Peyronie's or penile curvature. And finally, why we are so confident when we come to our clinic saying we can get you hard again is that we have penile implant surgery. This type of surgery predates Viagra. And what it allows for is spontaneity. It's essentially we surgically implant, and it's pictured here, but we can surgically implant these inflatable cylinders in your penis with a control pump in the scrotum and a reservoir in the abdomen somewhere. And whenever someone wants an erection, they just pump it up physically themselves, and when they don't want it, they just take it down. There's also a version of this surgery where you can put in sort of semi-malleable rods that you can sort of bend up and down when you want to have sex and when you don't want to have sex. Again, very high satisfaction, very rigid, hard erections. There's nothing on the outside that looks like there's something on the inside, so it can be concealable. And there's no impact on appearance and sensation. The limitations is that it does require surgery, and it is not a minor surgery, and there's surgical risks involved. There's no going back to other options, so you can't say, oh, never mind, let's like take this stuff out, let me go back to injection, let me go back to pills, because to place these implants, we sort of remove the native tissue that is the erectile tissue. The implants last anywhere from about 10 years. And there's whole talks that we dedicate to this. But this is something that urologists that are fellowship trained in what I do can offer patients. I get a lot of questions on emerging therapies. So patients ask about shockwave. I've heard acoustic wave therapy, stem cell injections, other pills I've seen ads for. Let's take a look at those too. So low intensity shockwave therapy is also sometimes marketed as acoustic therapy, and some brand names are like Gainswave. You might have heard of that. The advantages are that. So what is it first? It's basically producing acoustic waves that transfer energy to tissue that leads to sort of microscopic stress. So you're straining the tissues. And preclinical studies, so not in humans, but the animal studies have shown that there's sort of neoangiogenesis, so aka stem cell, blood vessel sort of growth. That's a recruitment of progenitor cells and resident stem cells. Microcirculation is improved. There's a theory that some of these stressful energy shocks can break loose microplaques in the vasculature. These are things that we can't see on imaging, but are theorized to be there. It causes vasodilation and a subsequent increase in nitric oxide, decrease in fibrosis, nerve regeneration. Again, these are all sort of preclinical studies, so these are all theorized how they work. There's what I like about this is that, again, non-invasive is maybe the only quote restorative therapy. So all the other therapies like pills, injections, gels, men complain saying, well, this is just a band-aid. It's not treating the underlying issue. And now you know from this talk that the underlying issue is really like the cardiovascular disease or diabetes or medical condition that sort of lead to these things. But it can restore some things. The limitations are that it's pretty high out-of-pocket costs. It's basically thousands of dollars to get this done. It's not covered by insurance currently. There are some things in the works where they might be covering it or have a coverable CPT code this year or next year, but institutions offering it probably haven't caught up to processing it. It requires multiple in-office treatments, so usually once a week or twice a week in some studies, but usually once a week. And the major thing is that robust clinical data is very mixed. I tell people it's kind of a half step if it does work. And some people that Viagra works and they want to have that sort of benefit, but not have the side effects. This may be a good fit. if, let's say someone's like really sort of having severe ED where the injections aren't working great, and they're like, hey, will this work for me? I usually tell them no to save their money. Buyer beware out there, because a lot of sort of shockwave clinics will just do this on everyone, and really, I think, have no um, data backing their recommendations to do this. But what's sort of the saving grace of this technology is that there's, again, no documented adverse events. So maybe some penile soreness, but there's no like scar tissue bleeding or like dangerous things happening. So I think the cash clinics are getting away with it. Um, and just buyer beware, again, not all shockwaves are the same. So on the left side is what's called focus shockwave. That's like a more medical grade machine that we use out here at Stanford and many other institutions, like reputable institutions across the country. And the tissue penetration depth is higher because those focus ultrasounds are going deeper. The radio wave probes, and you have to ask whatever clinic you're asking about this. If they have a radio wave probe, that the energy is dispersed too early and it's staying too superficial to reach what it needs to reach. And so, something to think about. I usually tell people, if you're going to spend like $3,000-4,000 and I told you, and in the end, like nothing really changed. If you're like super, super pissed, or you like, are like distraught that you like took out extra credit card debt or something for this, I tell them, like, don't do this then. Your money's and time is better spent probably one of the more proven therapies I talked about earlier in the talk. But I do have patients that want this, that seek it, and I think it's a valid therapy now. And actually, the European guidelines just made it into their guidelines, saying that yes, it's a guideline approved ED therapy. It hasn't quite made it yet in the United States in terms of the guidelines, but it's offered. So and at Stanford as well. People ask about platelet-rich plasma, stem cell therapies, P-shot. The idea is that we're like concentrating the growth factors in your plasma and we're sort of injecting into your penis. I think mechanistically, whatever they inject into the penis will just like leave the penis through the venous outflow right away. I don't know how to keep it there. Even if they try to keep it there, none of the studies have really shown any benefit. So at this point, this is just experimental. But if you're paying for it, then you're just paying for an experimental, non-proven therapy at this point. And because it's not really studied very well, we don't really know the long-term side effects also of sort of injecting these therapies into the penis. So at this point, we don't offer this at Stanford, and it's thought as investigational. This is probably one of the, again, more newer kids in the block. Now there's a bunch of off-label medications and compounded combos you'll see, and so these are some of the ads. It's very easy to see these ads of Google search. But what they usually do is add like Viagra and Cialis and compound them together and then throw in a couple other extras. And one of these extras, commonly, there's apomorphine and oxytocin, some of them that I've seen. Apomorphine is a dopamine agonist, so it is a Parkinson's drug. So just if that scares you, be careful. So in studies that have shown just apomorphine versus placebo, it was better than placebo for erectile dysfunction, actually. And it was sort of approved in many different countries for the treatment of ED. However, it was not as good as the PDE5 inhibitors, so the Cialis and Viagras. And so basically they fell out of favor and people stopped sort of selling them and using them. This was back in the 2000, like the studies are 2000, 2001. And I guess what's, old is new again. That they're sort of it's adding it back in, saying that there were studies that supported their efficacy, and they said, more, like, why not more? So the Viagra, Cialis, why not throw some extra stuff in there? It's not really been proven. If Viagra and Cialis were not working for you, I think throwing in apomorphine wasn't going to do much more or much extra. And then again, so the 3-in-1s are daily Cialis, Viagra, and apomorphine. And there's like a 4-in-1 that has also oxytocin in it. It's a bonding hormone and also it modulates dopamine pathways. And to take a step back for both these things, dopamine is like the excitatory neurotransmitter. So it's like it's an excitation, and it's leading and tied to like libido and orgasm. And so the studies have shown that with sexual stimulation, there's higher plasma levels of oxytocin. And so I guess that's some of the rationale behind using this. That okay, there's more when you're having sex. If we give you more, maybe it'll make sex better. Again, not proven. They can compound whatever they want and sell it. So it's sort of, again, this is like a buyer beware page essentially. We're nearing my portion of the talk before we start open to questions. But take-home messages are: number one, if you have new erectile issues, like if you don't have a PCP, get a PCP. If you have new erectile issues, talk to your PCP, and sort of, the visit should more be like, okay, how am I doing cardiovascularly? Like, Have I had my cholesterol checked? Have I had my A1C checked? What's my blood pressure like? What's my risk of having an MI? They have different calculators and risk scores that they can do that put in your data so they can sort of have that talk started. Whatever's good for your heart is good for your penis. So this is a chance to really optimize your health of just, if you've needed something to motivate you to get off the couch or, get away from Zoom and be active, this is the chance. Number three, there's quite a lot of things we can do to optimize your use of Viagra Cialis before we just say, this doesn't work, move something else. And four, there's always hope. Erections can be restored with the right treatments, and the right attitude and the right specialist that you're going to see. So, um, and now open the floor for questions.
Thank you, Dr. Chen. What would you recommend for those that are recovering from prostate irradiation and ADT therapy?
Yeah, this is a common population that I see in my clinic actually, because I'm part of the Stanford Cancer Center sort of penile rehab team essentially. That's a whole talk in itself. But if you're newly being treated, I recommend starting with the basics. There's like daily Cialis that we put them on, even if it doesn't work getting erections. I think some of that blood flow boosting actions of Cialis can be helpful. And I actually recommend patients use vacuum erection devices daily, not for sex, but in patients that have been radiated or have prostate cancer treatments like anti-hormone therapy, the penis can shrink over time, and maybe more severely so than someone else that didn't have these treatments that also had a similar time of disuse. And so the vacuum pump with daily use can sort of restore some of that length. And oftentimes these men may need some help by using injections or gels and may have a higher chance of ultimately needing to progress to implants. And I also take this chance to say, like, some men will get to the like, do I go for the implant or do I just not have penetration be part of what I do? And that's a very personal decision. I have patients that say, no, I'm good. I'm like old enough. I've had a good run of it, and I'm having plenty of pleasure with my partner with other means, and that's totally okay. So I always sort of want the patients to know all their options before they jump to the implant.
Can PSA biopsies cause erectile dysfunction?
That's a good question. So they can, but typically when they do, it's usually like a temporary sort of erectile dysfunction. And why that is, we didn't go into the anatomy that far up, but the nerves that, the signaling that tell the penis, the arteries to, nitric oxide and all that, those nerves are around the prostate. And when you have surgery, those are the nerves that try to spare and keep intact. But because those nerves are on the prostate, the periphery, and because cancers are near the peripheral, in the peripheral zone of the prostate, sometimes like this biopsy needle might go through those nerves. But there's such a quick intervention. I suppose the biopsy needle gun goes in and out so quickly that I think this causes a nerve palsy. But for it to cause permanent ED, I don't think the mechanism is quite there. I do hear a lot of men saying I had an ED ever since my diagnosis, and I do think there is, if they are newly diagnosed with prostate cancer, there may be a new sort of stress element to their life that may be compounding the effects of this temporary nerve palsy from the biopsy.
What's the role of pelvic floor therapy for ED?
Pelvic floor therapy is an interesting one for ED. In that I think I don't list it as a therapy, but I think in special cases, if someone comes to me and they don't have a lot of these other risk factors, like it's like a young guy that like late 20s, like never a smoker, doesn't vape, doesn't do a lot of things, pretty healthy, and they have they're complaining of ED, we do start them on the PDE5 inhibitors, but depending on their physical exam and their history, if they have other symptoms of a tight pelvic floor, then sometimes physical therapy can help with that, because you can have such a tight pelvic floor. It's like the muscles in their pelvis that kind of are like the bedrock of your pelvis. It can be so tight sometimes that can cause like restricting blood flow, actually.
How does anemia interact with ED?
Anemia doesn't interact directly with ED, but when I hear that, my first concern is probably like, oh, what's causing the anemia? Anemia kind of a wide differential, so I don't want to scare anyone, but is it low testosterone? Is it renal disease? Is it cancer? Is it the result of some treatment from prior? So I look at sort of the cause of the anemia and just have the anemia be another sign of your overall health.
Would going a long time without penetrative sex affect the vasculature?
Not necessarily, no. I said the penis is the usual organ. The penis has its own sort of self-care mechanism. That's why, we have these morning erections. And so you can go a long time without penetrative sex, but if you have regular erections, either spontaneous nocturnal morning erections or with masturbation, I don't see a problem there.
What therapies work best for men over 70?
It goes back to sort of what's causing the ED, and there's no one best therapy for any specific age. So we usually just start people if they haven't tried the PDE5 inhibitors, they try the PDE5 inhibitors, Viagra, Cialis. If they tried it before and they don't want to waste time retrialing it, they train doctors and the doctors before have tried things. Then we just sort of offer everything that I just offered today and just have them pick what they want to do. It's usually a balance of what does your partner want, how spontaneous you want it to be, what's your sort of out-of-pocket cost limitations, all these things go into what we decide on.
What is the effect of prostate removal on ED?
So ED is a very significant consequence of prostatectomy, and I'm assuming radical prostate for prostate cancer. The surgery, I tell people almost guarantees at least a temporary drop off in erections, and there's a long sort of 1 to 2 year recovery where if they're able to spare the nerves, that the nerves can sort of have time to come back. I gave a whole talk on specifically penile rehabilitation after prostatectomy or prostate cancer treatment. That's through the cancer center. There's a YouTube video, and I guess to my chagrin, it's gotten more views than I thought it would. So it's up there as well if you want to listen to that.
Do you recommend any specific type of bike seat to improve circulation? And can prolonged lack of circulation cause permanent damage?
That's another. There's so many controversies in sort of men's health, and that's another one. Does chronic or long bike rides cause ED? And the theory was that if you based on the saddle, if it's a very hard-nosed saddle, the way you're sitting on it, it might be sort of compressing some of the pudendal arteries or branches causing ED. And there are some people that think that, yes, the hard-nosed saddles are bad and that they're causing this issue. There's no right or wrong answer. I think if you're biking so much that you are having saddle numbness, then you might need a different bike seat. So some of the flatter ones or with a hole in the middle. But they looked at studies, there was a UCSF study that looked at this, and there wasn't a very strong correlation. And essentially they basically said that this biking is probably better for you, for your erections, than it is hurting. Because what's biking come with? It comes with cardiovascular benefits, comes with probably social benefits if you're biking with other people. So don't stop biking just because of this. But if you are biking so much and that you're having numbness down there, that usually we should tell you to look at things a bit and change some things.
Is there a correlation between ED and diminishing sperm quality?
There could be if it's a central low testosterone or hormonal issue. I can see that. The sperm, I think the biggest common factor in my mind, just hearing that question, is age, because sperm and semen volume overall goes down with age, and ED does sort of is more prevalent as one gets older. But the reason for the ED part is just an accumulation of sort of lifetime risk factors for cardiovascular issues and blood vessel health.
Is acupuncture known to have an effect on ED?
Not a strong one. I see it as there's no harm to it. And so I think if it causes stress reduction and stress is a part of the ED, I think yes. I'm a big fan of just having patients and basically not poo-pooing these alternative therapies and just saying that I think it's an adjunct. Do I think that if you have if you have a history of an MI or a stent and you have ED because of that, will acupuncture do something for you that Viagra couldn't? Probably not. But could you use it with Viagra Cialis? Definitely, yeah, try it. I'm not against it.
Does the vacuum require sexual stimulation first?
The vacuum does not, actually, because it's a physical pulling in of the blood. And so that's one of those things where I think some patients that have libido problem, but who have a partner that wants some type of penetration, that's an option for them too. But good question on that one.
Does kidney disease...
Actually, I'll make a comment too that the injections and the gels, because they are sort of more potent and delivered right to the penis, they oftentimes do require less arousal. So when we give education on how to give patients, or how to have patients give themselves a shot in the clinic, what they get with the same dose, the hardness of the erection may be lower than when they do at home, because at home they have the more comfort and arousal state. So it does get you hard, but you get harder when you're aroused.
Does kidney disease interact with ED in any specific ways?
If you have, you know, the worse your kidney disease, and I'm thinking like patients that I have on dialysis, it can definitely affect your penile health and erectile health. Mainly, if you have uremia, that's not good for your vasculature. That can lead to ED. If you have, oftentimes people who have poor kidney function have hypogonadal issues or low testosterone. That can affect libido. That can affect penile tissue health. So definitely, again, like I think the penis and your ability to have an erection is a good barometer of your overall health.
After 10 years of experiencing symptoms, can anything still be done?
Definitely. It all depends, again, is it 10 years of your A1C being 12 that are often maybe more limited, but not zero? And, oh, sorry. Nope. But we never say it's too late. We always kind of just reassess where you're at, what your comorbidities are at, and what have you tried, what you haven't tried.
Are Trimix injections different from the ones in your presentation? And if so, how do they differ?
Trimix injections are a type of, so intracavernosal injections are the category of basically putting medication into the penis through a needle. And so Trimix is one of them. It's a common one.
Well, thank you so much, Dr. Chen, for your talk. Thank you to everyone for joining us this evening and listening to all this great information. If you'd like additional information or resources, please contact Stanford Health Library, and we'll see you at our next talk.
Okay, thanks everyone.